So thank you very much, Julia. Good morning, everybody. My voice is a little bit out because I've been having this head cold for the last couple of days, so please bear with me. So I've been tasked with talking about the immune response and perioperative inflammation and something quite arrogant. Can we actually influence outcomes in cancer patients? So I do not have any disclosures of conflict of interests to declare to this topic. The only thing I do have to declare was that I was a cardiac anesthesiologist until 2016 before coming to Memorial Sloan Kettering. So I've been playing catch up, and I give a little bit of an outside view on this topic. I have not been in the onco-anesthesia world for the past 20 years like my esteemed colleagues have on this panel. So what are the objectives? Let's try and understand what the immunological pathways are, stress response, and how do these promote recurrence or survival in oncological patients? And more importantly, are there any factors that we as perioperative care providers can manipulate and optimize? So before we even get to the perioperative period, when I first came to Memorial Sloan Kettering, I was very interested in looking over the fence at what our medical oncology colleagues are doing, because I wanted to find out more what's the hot topic right now in oncology. And for those of you that aren't really working in the oncology field, it is the immune system and the utilization of the host, the patient's own immune system, to identify the cancer and to use it to combat and destroy cancer. This is a paper right now from the New England Journal of Medicine. Some of you might recognize these drugs, nivolumab and ipilimumab. This is a PD-1 receptor antagonist, and this is a CTLA-4 receptor antagonist. You summarize these pathways under checkpoint inhibitors. And on a side note, the ipilimumab, the CTLA-4 pathway, that was awarded the Nobel Prize last year. So this is something that has caught the attention of the medical community. And let's just take a look at what we're seeing here. These is metastatic melanoma. These are classic survival curves of what has been going on for the past 100 years in melanoma. If you look at 36 months, the survival is abysmal. It's in a couple of percentage, all right? Since these checkpoint inhibitors have been used, you can see that survival curves at 36 months are now anywhere between 30 and 60% almost. So it's really quite revolutionary, the advances that medical oncologists have made. Here's some CT pictures. You can see how the tumor cells here, this is a patient again with metastatic melanoma. After only 12 weeks of treatment with these checkpoint inhibitors, they melt away like butter in a frying pan. So how does this work? One of the ways tumor cells survive is that they have this ability to cloak themselves from the immune system, because the immune system should recognize these cells as foreign, but it doesn't. And we're sitting here right now, and all of us are making tumor cells, believe it or not. But our immune system is surveilling, and the natural killer cells are identifying these cells as foreign and are scavenging them out. So the question is, why do some people go on to develop cancer and others don't? Why do some people go on to develop metastasis, why other people don't? A lot of it has to do with this interaction between the host's immune system and the cancer cell. And these checkpoint inhibitor pathways are really quite fundamental. Tumor cells express them, and it's one of the mechanisms that the tumor cells have developed to sort of cloak themselves from the host's immune system. So let's go back now to the perioperative period. All right. When I first started looking into this and I read the literature, and many of this were published by VJ or by Wankata, and I started telling this to my colleagues, my anesthesia colleagues, they were like, "Are you nuts? Do you seriously think that we who take care of the patient for 4, maybe 6 hours, maybe 12 hours if it's a long flap case, that this brief period of time, it's only a very narrow interval in the patient's total care, that we during the short period of time can actually do something, participate in the care that will project then a change in the patient's course, let's say a year to 5 years down the line." That's actually something quite arrogant, which is fine because, like I said, I was a cardiac anesthesiologist for most of my life, so that's what I did here. But I do think that there is some literature out there, or there is a rationale for this assumption. This is a nice paper that I found while I was reviewing, and it sort of lays a foundation for me of why the perioperative period, why the phase when we're taking care of periods is so important and actually can influence patient outcomes. So this is a study which already is almost 20 years old, in Japan, where they were looking at colorectal surgery. And even if no touch technique, that means our surgeons are really trying to isolate the tumor as well as they can. You can see that in 52 patients where they sampled the blood before resection and then after resection, downstream in the portal venous system, right? The venous system that would drain the cancer, the region where the cancer was in these patients, that 16 of these 52 patients, they were able, via polymerase chain reaction, to identify that tumor cells were in the systemic circulation. So what I'm trying to show you is that when surgeons do their resection, and as we heard before, surgery is still the mainstay in treatment of oncological disease, and that's not going away. When the surgeon resects, he or she is going to touch the tumor, even if we talk about no touch technique, minimal invasive surgery, and so forth and so forth. They're going to be touching the tumor, and you're going to have some spread into the lymphatics or into the systemic circulation. So that's, I think, something which is fundamentally important to understand. Here's a review from the British Journal of Anesthesia, and it shows you 9 key factors that can influence the immune system. Remember what we were talking about, the immune system and the cancer and how they interact together. And these are factors that influence the immune system. Surgery, I'm going to talk a little bit about the normal perioperative course of the immune response during surgery later on, but look at the systems here and you're going to recognize something. Pain, drugs, opiates, these are all under our direct control, and so is hypothermia. If we don't control these things, who do? Who does? So, the systemic immune response after major trauma, which we could also consider surgery under major large surgical procedures. You have tissue injury and hemorrhage, and different systems are activated. We like to look at these systems in a linear sense, but really they're more of a network that interact together. And most importantly, these cell detritus, so in other words, these waste products from cells that have lysed, they stimulate the immune system, and the immune system goes in there and has a response, a systemic inflammatory response. Depending upon how the immune system reacts, in other words, which inflammatory mediators, which cytokines are produced, you can either have an upregulation, which goes towards these Th1 helper cells, which stimulate the natural killer cells and the cytotoxic T lymphocytes, which would destroy tissue or cancer cells, or you can have an immune inhibitory response with these Th2 cells, which then lead to a suppression, and that would, of course, aid cancer cells in our specific population. So usually after having a major insult here, you initially have an activation of the immune cell, and then you have a suppression of the immune system. Now you might say, well, why do we have that? It actually makes perfect sense. So when you have tissue damage, the first thing that you want to do is you want your immune system to go in there. You want to shut off the border so it can't go any further into the organism, and you want to destroy the dead tissue. You also want to inhibit microorganisms from coming in there. But after a couple of days, you actually want to turn off the activity of the immune system, and you want it to be inhibited, because what you fear is that the immune cells might start recognizing self as foreign, and you get then autoimmune reactions. So this system actually makes sense. But our patient population is different than the normal patient population for the reasons that I just told you about. We don't want large or long-term immunosuppressive states in the cancer population, because that's what cancer cells enjoy. That's how they thrive. So this is a nice schematic that I found here in Current Opinion of Anesthesiology. It shows you this nice scale drawing here. Normally we're in an equilibrium. Depending upon which cell line is produced by the local milieu, you could say, of the inflammatory system, you either go over here to this elimination, the cytotoxic area, or you go over here to this immune suppressive area. Now look at some of the things that promote one or the other, and this has all been done in basic science research. This is where all these ideas have come from. Now I'm deliberately not going to go into basic science with you. I'm going to try and go one step further and show you the data that's out there in clinical medicine. But what will catch your eyes as anesthesiologists very quickly are, of course, two of our most favorite drugs, propofol and volatile anesthetics, and they happen to be on different sides of the scale. So the question arises very quickly then, well, does it matter which agent we use for hypnosis during a general anesthetic? And this was a paper that was published from England from Tim Wigmore's group, and this sort of rocked the world when this came out in 2016. Note, this was the same time that I left cardiac anesthesia and came to Memorial Sloan Kettering, and I thought, oh, this is pretty cool. And what this was is a retrospective design. He propensity score matched about 2,500 patients in each group, and he looked at the difference of drug that was given, whether it was Ativo, which was propofol and Remi, or whether it was a volatile agent with an opiate. And what he was able to show, and this was quite remarkable, that there was a significant survival difference at 4 years between the choice of anesthetic that was used. Propofol patients did certainly better. And he sliced and diced the data as well. He looked here at healthy versus sick patients, which he divided by the ASA class. So the top curves, you can see those are ASA 1 and 2 patients. The bottom curves are ASA 3 and 4. Clearly the 3 and 4s did worse, but there was also a difference here between the choice of anesthetic that he chose. And finally, he also looked at whether metastases were present or not. And again, there was a statistically significant difference could be found between the groups. The next year, a paper came out looking at esophageal surgery and the choice of anesthetic. And here they saw very similar results that remind you of the Wigmore paper and the results that he found there. Unfortunately, this year, anesthesiology published a paper looking specifically at breast surgical patients with breast cancer, and they also had that same question. Was there a difference between propofol and volatile agents? And you can see here from the curves that both in recurrence-free survival as well as overall survival, there was no difference. However, for those of you that read the appendage to the Wigmore trial, you'll notice that the driver for the survival benefit of propofol in the Wigmore trial was not breast, but was GI tumors. If you just looked at his breast tumors, he would have found the similar results that this Korean paper found as well. All right, and that's an important theme that you're going to hear throughout my talk, is that we should not lump cancer into one bucket. But I'll get a little bit more into that later on. So what else is here? Peripheral nerve blocks and the activation of the sympathetic nervous system, the hypothalamo-pituitary adrenal axis, all right? These are also two things that are on the other sides of the scale. This also received a lot of attention starting in 2006 when this first trial was published showing breast surgical patients, one population receiving paravertebral blocks, the others just a normal general anesthetic, and to many people's surprise, the patients who received the blocks, they did better. Now the question is this because of blunting of the sympathetic response? Was this because they used less opiates? Was this because of potential tumor necrotic effects of the local anesthetic? You don't know. But what they were able to show here in this retrospective trial was the patients with the blocks did better. The same data was able to be shown for patients undergoing epidural for radical prostatectomy. We at Memorial Sloan Kettering, we also published a paper here looking at large debulking gynecological procedures, and we were also able to show a survival as well as a recurrence-free survival benefit in those patients. Some more trials that came out here. This was looking at colectomy patients. This was querying the Medicare database. So we're looking at 42,000 patients where 23% of them received epidurals. And there was also a survival benefit of the epidural population here. And this wouldn't be complete without showing you a Mayo Clinic database review, which also showed a survival benefit in this patient population. So you can see that there is quite a large amount of literature mounting showing that regional does have benefits. However, like I showed you before, with the volatile. There is also literature that shows that there is no advantage. I'm just showing you one paper here, but there are other papers out there which weren't able to show a survival benefit. Let's move to morphine. Opiates. Opiates have received a lot of attention in the press lately, not only in cancer biology, but because of the addiction potential. When you looked at that JAMA article, 1 out of 10 patients who receive minor surgery are still on opiates a year later. The death rate because of opiate-induced intoxications are huge. So opiates are really interesting, and there's a fair amount of literature out there, especially in basic science, showing that opiates inhibit the inflammatory response. Remember what I told you before, bad or inhibition of the inflammatory response is good for the tumor, bad for the host. And opiates don't only inhibit the inflammation, but like Julia said before, as soon as the tumor reaches a certain size, it requires angiogenesis. It requires blood flow to survive. Opiates promote that. So overall, there's a lot of basic research that would point to opiates being bad in cancer patients. This is an interesting basic science paper. I know that I promised I wasn't going to bring too much basic science, but I lied. This was where they looked at patients receiving large and low-dose fentanyl dosages, and you can see this is almost like a cardiac case here, 100 mics per kilo. This is more of a normal general anesthetic. And the interesting thing here is the cytotoxic N killer cell activity. Here in the beginning, they're both the same between the large and the low dose of fentanyl. At 24 hours, they're both depressed. But at 48 hours, you can see here that the small dose fentanyl, the immune system has returned to its normal activity, whereas the high dose fentanyl still is blunted. Now, I was looking here at activation of the opiate receptors, but it's also interesting to look at what happens if you knock out the opiate receptor. So what happens if you antagonize them? This is a drug, methylnaltrexone. It's a drug, it's a peripheral opiate mu receptor antagonist. And it's given to patients to combat some of the side effects of constipation, which is common in cancer patients, end stage, because of the opiates that they receive. And what you can see here is patients who received this drug, they had longer survival rates. And if you looked at the patients who received methylnaltrexate, the ones that had a response to the drug, in other words, the ones where the constipation got better, they had a survival benefit to those patients where the methylnaltrexate did not work. And if you look at other disease processes here, which also non-oncological disease processes, with patients who also had constipation and got the drug, there was no survival benefit. So there's something with this drug that it does on oncological patients, where knocking out the mu receptor peripherally does lead to a survival benefit. Juan Cata, one of my panelists here today, published something that I thought was absolutely astonishing, because the general consensus is that opiates are bad, right, in cancer. But he published a paper here where he looked at esophageal cancer, looking at adenocarcinoma and squamous cell carcinoma. And what he was able to show in the adenocarcinoma, the dosage of fentanyl did not have an effect on survival. However, in squamous cell, there was an advantage in survival, not of the patients who got less fentanyl, but those patients who received more fentanyl. So just the opposite of what everybody else is saying. And stuff like that always catches my attention. I always start asking myself, how is that possible? How can giving more opiates, if the world and everybody is saying that opiates are bad, all of a sudden relate in a survival benefit? And I think a lot of this has to do with us not throwing cancer into one similar bucket. And finally, blood transfusions I would like to look at. This is a nice trial here. Again, basic science on rats. You can see these rats got synogenic blood transfusions. That means the same genetic makeup versus allogenic, another genetic makeup, and then leukodepleted allogenic. And what you can see here is that the ones who had synogenic and leukodepleted allogenic, they had 5-fold less lung metastasis than ones that got allogenic. Again, the immune suppressive effects of blood transfusions, which is something that we have known for a long time. Think of kidney transplants back in the 60s when you gave patients 2 units of blood before the kidney transplant. They did a lot better than the ones that didn't. Another analysis here showing transfusion and outcomes, and you can see here that both in disease-free survival as well as here in overall survival, that receiving blood transfusion in cancer patients was associated with an increased mortality. So what are the future directions? Where are we going with this? Like I kept saying, cancer is not a homogeneous disease process. Yes, this is a delicious fruit salad, and those are all fruits in there, but we all know that pineapples, mango, and banana, they taste a little bit differently, and that's kind of how we have to start looking at cancer. And again, I like to look over the fence at our medical colleagues. Medical colleagues don't call it lung cancer. They break it down into small cell, non-small cell, and they even break the non-small cell down into adenosquamous cell and large cell cancer. And nowadays, they go even further. They break it down into the individual oncogenetic mutations. Does the adenocarcinoma have an EGFR mutation, a P53 mutation, and so on and so forth? And there are drugs now that are being FDA approved that don't even care what type of cancer you have, but what your genetic mutation is. That means if you have a sarcoma, a uterus carcinoma, if you have melanoma, it doesn't matter. If you have the genetic mutation, you qualify for that drug. And I think that's where we basically have to be going as anesthesiologists. The global statement is opiates are always bad, volatile agents are always bad, regional anesthesia is always good. It's probably wrong. We have to look at cancer more at the individual basis of the cancer that we're seeing. It is a complex network. The disease changes the network. Giving drugs changes the network, but you hope when you combine both of them that you get the patient's network back into sync how it originally was. And this is complex. Their genetics, epigenetics, their proteomics, all these factor into how patients will react to our interventions. And that's why when you just use cancer as a global thing, the literature is very heterogenic. At least that's my thought process. And all I can say is that we have a very long road ahead of us. We're right at the beginning, and I look forward to coming back maybe in 2-3 years and show what we have been able to achieve. So I thank you all very, very much for your attention, and I wish you a nice day.